Hi, Carmen. Hi.
Hello.
How are you?
How are you doing? Good.
Good. So most people have accepted the invited,
Great.
the invitation. So I think that we're set up on this side, right? So I'll
Great.
name you host,
Good.
and I'll stay a little while just to make sure that everybody is all right. Okay.
Great.
Thank you. Okay, have fun.
Thanks.
Thanks.
Thank you. Hi, John.
Hi, Carmen. How are you?
Good. How are you?
Good. I'm good.
Great.
Thanks.
Okay. So we can wait for people to start connecting.
Yeah.
I'm gonna go close the door because I have a lot of noise, and I'll come back.
No problem.
Hello, good morning and good afternoon to everybody. How are you doing today? We can maybe wait a couple of minutes to see if more people connect. In the meantime, we have decided in the committee to try to make these seminars a little bit shorter so that we don't, so everybody can connect and stay the whole seminar. So I will ask John today and for the next presenters to try to stick their presentation to 30 minutes and then maybe have around 20 minutes for discussion, so that the seminar is not longer than 1 hour. So that's our aim. So today, John will present to us this presentation, which is called Developing an Index to Assess Global Coverage with Key Health Services Using Antenatal Care Coverage. Maybe John will like to share a presentation.
Thank you very much, Carmen. Let me share the presentation first. Good, I think it should be up now. Great. Let me know when to start.
Yeah, we can see it.
Okay.
I think we can go ahead and start.
Good. I think it's better for me to switch off my video, but at least people get to see me quickly before I do that. Good afternoon, good morning, good day, everyone. Welcome to this, our PEP seminar series. I've not been feeling very well for the last 1 week or so, but I'm kind of bouncing back. So I might be a little bit slow, but I'll try to fit in the 30 minutes, as Carmen said. Today I'll be talking about the research I've done and still refining to develop an index to assess global coverage with health services within the context of universal health coverage, but using antenatal care as the window. I will kind of breeze through this because of time. So it will just be a matter of motivation overview, blah, 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 blah. Skip that for time. Now, the motivation behind this is that there's a global concern in terms of especially within developing countries, that maternal health indicators are not adding up, and things and either not adding up on one side, and things they're not doing well. Countries are not doing well. And this also applies to child health indicators, kind of move hand in hand. And within the context of the MDGs, before the SDG era, maternal mortality really featured prominently. And that still continued even down to the SDG era. And SDG 3 specifically talks about reducing maternal mortality ratio to anything less than 70 per 100,000 live births by 2030, about 9 years' time. And also in terms of child mortality, reducing neonatal deaths in neonates to about 12 or less per 1,000 live births by 2030, of course. And we know clearly that to be able to achieve these two key indicators, we need to target pregnant women. A lot happens during pregnancy that really affects newborns as well as maternal mortality. And one of those things to look at is skilled birth attendants. And before skilled birth attendants, we also have antenatal visits. Now, because there is a strong correlation between antenatal visits, antenatal care visits, and being attended by a skilled birth attendant, one would naturally want to look at antenatal care and coverage. If you bump that up and you have very good antenatal care coverage, there will be a very high possibility that women will use skilled birth attendants for delivery. And we know from the MDG era that antenatal care coverage was one of the MDG indicators. And even though it wasn't explicitly mentioned within the SDGs, but like I said, it's kind of within the context of maternal mortality and neonatal mortality, you cannot run away from antenatal care coverage. And these are statistics from across the globe. You would see clearly that Africa is not performing well in terms of maternal mortality ratio. Africa has the highest, you can see there, followed by Eastern Mediterranean. In fact, the global average is being pulled mainly by Africa, even though Africa exceeds the global average by far. Neonatal mortality rates is pretty much the same. Africa leading the chart there, not doing well again. So therefore, I think it's important for us to see how we can assess antenatal care coverage and also to be able to close any gaps in antenatal care coverage. Bit of history for people who are not kind of used to the health sector, because that's where I spend the bulk of my career. Before 2016, the WHO usually recommended that women should have at least 4 ANC visits. And that is, of course, the case for uncomplicated pregnancies. There is no limit for complicated pregnancies as the need arises. Because the thinking then was that with at least 4 ANC visits spread across the 3 trimesters, we are able to give effective maternal health care intervention to women. And also because of the fact that there is a very positive relationship between antenatal care coverage and health outcomes, like I said. If we target ANC, we'll be able to improve maternal health as well as child health. However, post 2015, that is by 2016, WHO revised that recommendation, and the recommendation now is to have at least 8 ANC contacts. Note the difference, not visit, but contacts. And the difference between the contact and the visit is that contact, you could have visit to a health professional, not necessarily because of ANC, but whilst you are pregnant. So that is counted as a contact, because if you have to visit a health professional while you're pregnant, of course, pregnancy would have to be mentioned as one of the conditions, not that has to also be looked at. So, and WHO now extended that to 8 contacts with a health professional whilst pregnant. But that again is spread over time. This is more or less like the model. Previously, it's your first contact with the health professional should be within the first trimester. Similarly, the new model, and of course, the rest is spread across, as you see. There's heavy focus on having more regular contacts towards the 3rd trimester, the last trimester before delivery, for so many reasons, mainly medical. Great. So in terms of taking off, we already know that I'll use the 4 ANC visits, okay, as a starting point, given mainly that data we have data from the pre-2016 era. We already have data from the post-2016 era coming in yet. But if you look at ANC, having at least 4 ANC visits or 1 ANC visit, you do not capture it. Those indices, for example, the proportion of women who've had at least 4 ANC visits, that proportion is not sensitive to policies that countries may make, for example, to push women away from at least having 1 to 2 to 3. So countries that have made tremendous efforts in increasing the proportion with at least 1 or at least 2 may not be captured until you begin to make at least 4 ANC visits. It's just like a switch function. So nothing counts until you hit 4, then it begins to count. And the counting is flat. It's a flat line. Once you hit 4 and above, it's counted as 100%. Anything below 4 ANC visit is 0. So between 0 and 1, you switch between 0 and 1. So it's not sensitive to policies that countries have made to move women further to at least 4 ANC visits. And for me, that is something that is couched within the concept of progressive realization towards access to health services that is being missed. So we miss that progression. We only wait until we hit 4 or more, or in this case of 8 contacts or more, and anything below 8, we don't. If you have 90% of women having 7 contacts, for example, that country we have pretty much close to 0 coverage rate for ANC 8 contacts, which is problematic. So you cannot adequately distinguish countries because of that, basically. And again, these measures that exist do not account for quality of ANC services. So what this research is doing is to develop a simple index, it's not entirely simple, but very simple in the sense that it's easier for policymakers to understand that as opposed to a very complex index. So it's a simple index of ANC coverage in this case, but which can be extended to other things I would talk about at the end. But this specifically looked at ANC coverage. Using the number of ANC contacts or visits or whatever over entire distribution, not just looking at least 4 ANC visits. And also I tried to extend that index by generalizing to account for quality of ANC services received by pregnant women. So this is just basically the index quickly. The index is computed in a very simple way. You cumulate women from, let's take, for example, we start off here. We have at least women with at least 1 ANC visit will be, in this case, about 90%. And because it's cumulated, this is going to decline. So going this way or going that way to be either it is not non-decreasing if you're moving from left to right, and it's non-increasing if you move from right to left, because it's basically cumulated. So women with at least 2 ANC visits, in this case, is about 68% about, and women with at least 3 ANC visits is about 58%, and women with at least 4 ANC visits is about 35%, for example. So the index is such that we want to measure just this area, the unshaded area, as a share of the entire area. It's as simple as it is. That's what the index is I'm going to capture. And there are many ways that we can estimate that. You'll see in a while that it looks very simple, but it's a very powerful index in terms of capturing, being sensitive to many things. So it's basically the B divided by A over B, A plus B. And there is a gap. This gap is a gap that we need to fill. So whilst we want to maximize coverage, we also want to minimize the gap. So the ANC coverage gap is the shaded portion, and the ANC coverage area is the unshaded area. The beauty of this is that the 2 indices will add up to a unity. Okay, let's see why this is very important to quickly take a look at. In these 4 scenarios you see here, if we're using the old index, the result is the same. At least, in this case, we have 49% of women attaining at least 4 ANC visits in the 4 scenarios you see. However, one is better than the other, even though we know that in all of them, at least 49% of women attain at least 4 ANC visits. Panel A, you see panel A is the best. We have 49% of pregnant women attaining at least 4 ANC visits, and then all of the remaining attaining at least 3 ANC visits. So you see that distribution is closer to having universal coverage compared to, for example, panel C, which is 49% of pregnant women having at least 4 ANC visits and the rest having nothing, okay? But if you go by old indicator, it's these 4 countries should be on the same level, but they are not on the same level. So we want to see how countries move. Of course, we also have intermediate scenarios. These are arbitrarily selected just for an illustration to see what the index covers. So you'll see basically what I said here, that panel A is the better model, it's a preferred model or scenario to B, and B is a preferred scenario to D, and D is a preferred scenario to C. And of course, ANC coverage in C is comparatively the worst of all the 4 scenarios, even though in all countries, in all scenarios, 49% of pregnant women have attained at least 4 ANC visits. So now let's see how to generate that index. Because we usually work with household survey data that are kind of collected in such a way that they are discrete. And we don't have household survey data that will allow us to do the usual smooth continuous distribution. So we have to work with discrete points here. So here we define briefly a proportion of pregnant women who are between, of course, the usual age category with a live live birth in a given time period, who've had at least I ANC visit. I is arbitrary. Put in any number, you just cumulate. So you're accumulating depending on what the I is. If you notice from the previous charts, we had at least 1, at least 2, at least 3, at least 4, etc. That can be cumulated. Then the proposed index is IANC, which is basically it's a mean. It's a mean of the kind of sum of the cumulated proportion we saw earlier. So if you take your time to go through this, you would notice that it's basically trying to implement what I said earlier in terms of the looking at the charts I just showed. Now the corresponding gap is just basically 1 minus index, simple. There are also other alternative computation methods that can be used. This one is the one that basically censors the distribution. You fix the minimum at whatever level is desired. If it's 4, you fix it at 4. If it's 8, you fix it at 8. And you'll be able to implement this. Is basically the same result you get from applying. There are other methods that can be applied, but these are just 2 ways to do that. And to interpret the index, it's basically very simple. Having an index that is close, the coverage index that is close to 0 basically means that ANC coverage is extremely low. And having an index value that is close to 1 basically means that the coverage rate is very high. And by implication, if the coverage rate is very high, then the gap rate is basically tending to 0. And if the coverage rate is very low, then it means the gap, of course, increases. So it's a complement, like I said earlier. So for progressive realization, what we want to achieve is to reduce as much as possible the gap and increase the coverage rate. And now what I tried to do here was to generalize that index to account for quality of care. Because one of the challenges we have within the health sector is that most of these indices and indicators don't account for quality of services received by women. So 1 ANC visit, for example, is not the same. If the necessary tests were not conducted, if, for example, blood pressure wasn't taken, or sugar level not measured, etc. These are things that account for quality of services. But keep in mind, quality is multidimensional. So what this does is that we basically build into the model quality. Briefly, 1 visit will be discounted by quality. So if quality is 100%, then that 1 visit is counted as 1. If the quality is 80%, however quality is measured, that visit is counted as 0.8. So it's no longer 1, but 0.8. So the same way we accumulate the same formula you're accumulating, but now you're accumulating the quality adjusted visits, which will range between 0 and 1. 0 quality could result from no visit, and it could also result from the poorest quality you can ever think of. And 1 means there was a visit and is the highest possible quality you can think of. So pretty much the same application and summarizing to generate the index and the gap as well, accounting for quality. Briefly, which is also interesting, is that I had to pass the index through a couple of axioms to see how the index fares in terms of different properties. Anonymity, for example, replication invariance, focus, scale invariance, monotonicity, transfer axiom, normalization, and of course the very, very important one, policy, which is subgroup and decomposition. Not necessarily an axiom per se, but I think it's more of a property. And the reason why this is interesting is I borrows from poverty literature a bit and extends it to look at how we can assess service coverage broadly. Briefly, anonymity is a very simple one here to explain. So basically, if you take a distribution from the original distribution by arranging the distribution, you're not looking, no other information counts apart from ANC visits here. So we're not saying, well, you live in the rural, you live in urban, you're tall, you're not tall, you're black, you're white. No, nothing is relevant. The only thing that's relevant here is number of ANC visits. So by arrangement, it doesn't really change anything. The index will remain the same if you look at two distributions, one an arrangement of the other. And then also in terms of scale invariance. So replication axiom. For replication invariance axiom, basically we're saying pretty much similar. So if you're replicating a distribution from an original distribution, because it's a matter of replication, if every other thing remains constant, you don't expect the index to be different, the one you replicated and the original distribution. Similarly, for the focus axiom. Now the focus axiom, just like poverty, if you fix a minimum which is sufficient for good health of a woman, it could be 20, it could be 10, it could be 7. If that minimum is fixed, anything above the minimum doesn't count much. The same way with poverty, we begin to earn more than a minimum, the poverty line. It's basically not in terms of focus axiom. You're not looking at that. So that's pretty much the same here. So when a pregnant woman has attained at least the recommended minimum, whatever the minimum is, 4, 8, 10, whatever, and that woman reports more ANC visits, it doesn't change the index because the index is, of course, agnostic to that. Then the other axiom is the scale invariance axiom. If all ANC visits, of course, including the recommended minimum is multiplied by a certain fixed amount, which is a positive amount, of course, then you will not change the indices. They will remain pretty much the same. It's basically like scaling everything up. Nothing changes. Then in terms of monotonicity, when a pregnant woman with less than a recommended minimum attains at least one more ANC visit, the beauty of this is that the ANC coverage index improves while the gap reduces. This is what is missing from the previous index of at least 4 ANC visits. So if we record a woman with one more ANC visit, by implication, the coverage index will improve. And that represents the progressive realization we're talking about. Then we also have the axiom that talks about transfer. Now the transfer axiom, it's pretty much we using borrowing rather from multidimensional poverty assessments, as opposed to the monetary poverty where you can move certain amount from one individual to another. Same here, you cannot move ANC visits from one woman to another woman. So we're borrowing from how it is done within the multidimensional poverty literature. So in this case, for visits less than the recommended minimum, okay? And if visit less than the recommended minimum, So if you increase the number of women with fewer ANC visits, the index will increase, and it will increase, the increment will be less than that which will result from increasing the number of pregnant women with higher ANC visits. So as you go higher, it basically switches. So it gives that monotonous increase. So you want to be as much as possible closer to higher visits as possible. So it's basically saying the weight given to higher visits is greater than the weight given to lower visits, fewer visits rather. Then lastly, I think before I do the more like sub-analysis of decomposition, is a normalization axiom, which is a trivial one. Basically, if all women with live birth within a given period attain the minimum number of ANC visits, then of course it's trivial. The index is going to be 1, the gap is going to be 0. It's a very trivial one. Then the subgroup decomposition, which is interesting, is that you can decompose the index by mutually exclusive groups. So if, for example, you have 2 mutually exclusive groups with respective number of women in that group, you can generate the index as the weighted average of the index within each group. So you need to compute the index within each group and find the weighted average, and you weight it by the proportion of women in each group. So the weighting factor here is the proportion of women in each group. So if it's 50-50% rural urban, for example, the index is basically 50% of the index in the urban area plus 50% of the index in the rural area will give you the overall index. So I would breeze through this because now I don't have much time. I didn't know I was going to have 30 minutes when I prepared for this, but I'm glad it's 30 minutes so that we don't end up spending time here. We kind of implemented this using demographic and health survey data in sub-Saharan African countries, 35 of them, using recent data as they were available up until September 2018 when the core analysis was done. And what I found was that if you look at the 0.602, that is a traditional 60% of women with at least 4 ANC visits. However, if you go to my coverage indicator, that index that I've just proposed, you see the index is 0.854, which is higher than the 0.602, likely because now we are counting for lower visits because they really, really count. So if you increase any visit more that a woman receives, that index would increase, provided the visit is less than the recommended minimum. And of course, the gap will reduce. So the whole idea behind policy is to, as much as possible, reduce the gap and increase the coverage rate. Then we did subgroup decomposition as well across different mutually exclusive groups: quintiles, education, location, urban, rural location, for example. And the usual suspect, women in urban areas tend to have higher, this is Uganda, tended to have higher coverage compared to women in rural areas, and well-educated women had better coverage, as well as richer women had better coverage. So basically the index gives us the kind of news that we had wanted to see. Then this might be too small for you. We did kind of ranking of the countries within sub-Saharan Africa to see how this index performs vis-a-vis the previous index, which is at least 4 ANC visits. And to also note, it's not about the ranking that matters per se, but also what the index values mean for policy. So in as much as a country can be ranked equally high, likely because at least 4 ANC visits have close to 100% for ANC visits, which is pretty much what we saw from one of the axioms, then you end up having the same rank, especially at the tails, and that really happened. So the prediction was really, really true. So if you notice towards the tail, the ranks will remain pretty much the same. But the moment you move away from the tails, the ranks change. And that's basically to show us that it really matters in terms of the index we use, as one is able to capture progressive realization towards service coverage compared to the other. So we could see, for example, that even within the middle, there are changes where a country could have better, the new index being computed, better index value, but it will rank poor using the poorer using the ANC for visit. For example, I gave Malawi, Tanzania, Rwanda, for example. And it's also possible that a country could have very similar proportion of women with at least 4 ANC visits, just like the example I gave previously, very similar, but will have a very high variation in terms of the new index, likely because in countries where you have a large proportion of women with at least 3 or at least 2 ANC visits, the index value will increase. And of course, you could have better ANC4 ranking, but poor index ranking, and example of countries we're given. So to conclude quickly, using ANC4 visits alone to assess progress has been kind of shown that we miss critical improvements that countries are making. Countries are putting a lot of resources to increase the proportion of women attaining at least 2 or at least 3 gradually. It's a gradual increment. It's not a switch where countries put in a certain amount of money and suddenly you have 4 and more or 4 or less kind of. So women with fewer ANC visits likely come from poorer socioeconomic backgrounds. So it means that a country will continually demonstrate that there is no progress because women within a poorer socioeconomic ranks tend to have fewer visits and they will be less likely to hit at least 4 ANC visits, and that's not good for policy. So we need to be able to demonstrate that government funding to a large extent, or whoever funds such services, the fund is really going a long way to shift, to move women closer and closer to universal realization. So the new index that I propose provides that avenue to assess the progressive realization of access, in this case to maternal health services. At least using ANC, in this case, like I said, as a proxy. And what I didn't show was adjusting for quality. And it's important to note that if you adjust for quality, the results might be different, which is the new strand of analysis that I'm considering at the moment, which if I had time, I would have given a glimpse into what we're seeing in terms of Sierra Leone, for example, which is a classic case with a very, 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 very high coverage indicator, but very, very high maternal mortality. So you see a country that has very high, one of the best in Africa, if not ranked 2nd or 3rd on the continent in terms of having at least 4 ANC visits, but it's one of the worst on the continent in terms of maternal mortality. So that brings the issue of quality into focus. That it's not just about looking at ANC coverage, but we now need to build into that a measure that accounts for quality, and the index value will be reflective of what really is, rather than a spurious one that gives a very high coverage index, but in reality, women are dying. So the generalized index that accounts for quality will be something to be implemented. I couldn't do that immediately because of lack of quality indicators within the household survey, the demographic and health survey. So a related aspect, of course, will be delivery by a trained birth attendant, which of course can be predicted, like I said earlier, by having a very high coverage of ANC. If you had very good ANC coverage, there's a very high possibility that you will have delivery by a trained birth attendant. So for me, it's important to start with ANC rather than going straight up to birth attendants. You need to get the women into the system and then move them to a place where they can be taken care of, especially during birth. So women receiving quality ANC service will, of course, no doubt, be more likely to use trained birth attendants. So with that, I would really want to thank you. I hope I have not overstayed my welcome. But if you're keen, you could take a look at the paper in depth. If you really want to dig into the index itself and see how the index functions. That's it, the paper there. Thanks so much. I'll hand over to Carmen. Thanks.
Thank you, John. We can start with questions and comments. Maybe you can stop sharing the screen so we can see each other.
Okay, let me try and figure out how to do that now. Okay. I'm only seeing new share here. It doesn't tell me stop share. It is strange.
Let's see if I can help you.
Thanks. Just tells me new share.
Sharing.
Doesn't want to allow me to stop. Oh, good.
Yeah. Yeah. Okay. So thank you very much. That was very interesting, and you kind of stick to the 30 minutes. So thank you very much for that too. We have, I think, somebody, yes, Kibram has one question, and maybe after that, I would like to also ask you something. So Kibram, can go ahead.
Okay, thank you, John. I think this is very interesting exercise, and I like it, and I think this is very much interesting and a very good contribution. So I'm just thinking, like, so going forward, there are two points that I think would be important for this type of index. The first is to validate its potential to predict whatever access or coverage we have or you can get in any area. And I think, I don't know how best to show that, but I think one exercise could be to see if that predicts actual behavior, or if it predicts, I don't know, like for instance, maternal outcomes, or if it is significantly correlated with, I don't know, for instance, objectively measured access to health services. So I mean, I don't know how best to show that, but I think that's a very good exercise that you could think of. Second point is, are you thinking of this to be within country index, or it's going to be an index that can be used across country comparisons? And if you're pursuing the latter, I think it is going to be difficult to have an index that compares two countries, because they have a different health system, and I mean, I don't know if you can have the sort of information that can capture these variations across countries. And I think, because I think whatever indicator you use for quality, what is in a single visit itself is different across countries. So for instance, we know that, I mean, so in some countries, my wife gave birth in a Scandinavian country, and that is, I mean, the visit itself is completely different compared to Kenya or Egypt, where I'm now. So I don't know if you're thinking cross-country comparison, but I think you may reflect on that if that's something that you can think. Thanks.
So we have also a question. I don't know, maybe we gather 3 or 4 questions, comments, and then you can answer. I think they might kind of be related, because Jorge also asks, can you develop on the potential quality indicators that could be gathered realistically on the context of poor countries? And I had a comment on that too, because I'm thinking that yeah, gathering quality indicators might be difficult. So I was wondering if you can kind of give a weight or yeah, some kind of relative importance to one of the visits or another, but I'm aware that that might also depend on the country of interest. So if you want to do comparison across countries, I don't know, I'm not fully aware of how it works, but I know that, for example, in Uruguay, like the first visit, you do some certain things, and then on the third visit, you have the ecography. So the third visit is really important. So maybe you can kind of give a weight to the third visit, but of course that's gonna change across countries probably. And the other question has it's related to one last point you mentioned in the concluding remarks, that it's how this is related to actual mortality rates of mothers and children. So have you tried to see, because of this, the different indicators, if you just take the ANC4 or you take the index, so you have very different rankings. So how you can correlate that with mortality rates? That's my two questions. Maybe you can go ahead and answer, and then if we have more.
Let me start with yours, Carmen. Yeah, I totally agree that, well, there is no validation process to say one index, well, we can qualitatively say one index is a better index than the other, okay? Given, like I said, the fact that this index is able to capture progressive realization, the other doesn't, and they pretty much using the same data, okay? The same information, we didn't change anything at all. We can look at the indicators for example, if you build in quality, which is linked to your first question, if you build in quality into the assessment, the generalization of the method, the way it is written, is that you can change, you are liberty to choose how you want quality to be measured. The only constraint is that the quality measure should be range between 0 and 1, which kind of, I think it's sensible, rather than having an unbounded kind of quality measure. So you scale it however it's measured. I'll give an example of how that can be done, but you could range it from 0 to 1, with, like I said, 1 being the best quality, 0 being low quality, and each visit has its own quality, can have its own quality measure. So it's not a one size fits all. So now, in terms of changing the weight per visit, you can decide to weight visit number 3 more than visit number 1. However, it has to be informed by scientific evidence, either with gynecologists or people who are really into the field that will tell you this visit is a very crucial one compared to the other one. Then you could have expert opinion it is possible that all visits are equally weighted. If they are not equally weighted, then you can always tweak that. The challenge comes back to the first question in terms of whether you want to do cross-country comparisons. No, the index originally wasn't meant for, if you notice I said I ranked countries, it's of no value, but what I wanted to show was to be able to see what was before and what is now. And using only one country may not make a very compelling argument. It will be like, well, you did this in Uganda, okay, is that really generalizable? So I try to rank the countries to see what happens in terms of when you use one index vis-a-vis the other. But importantly, the index is meant to be used within country to track progress, like I showed for Uganda, between rural and urban, between quintiles, between different locations, hinterlands, just to show whether a particular area that is previously disadvantaged is improving or not. So that's basically what the index traditionally had wanted to make. So it wasn't meant for cross-country comparison at all. Then you also talked about validating the index in terms of seeing whether it predicts school performance or predicts many other things. Now, within the context of where we have been in health economics, there's something we call the social determinants of health. And that's why I was a little bit hesitant to link ANC visits and maternal mortality, because ANC visit is one ingredient in the equation towards maternal mortality. There are many mediating factors. I'll give an example. A woman could have like we find in Sierra Leone, you have all the ANC visits. It's possible that when you go back home, your cultural practice is militating against you doing well. There's a kind of concussion that it's kind of agreed in your culture that every woman who's pregnant must drink that concussion. Now, by the time you get to a health facility, the health facility doesn't know what you do at home, okay? The only thing they can record is we saw this person, we gave all the quality treatment we could, but we don't know why the kids are dying at birth. So there are many other things which are the so-called social determinants that mediate the relationship between having ANC and maternal mortality. Now, that is even within the health sector. However, we could try, like you say, to see whether these predict school performance, but one needs to map out that trajectory to see what is the transmission effect. How does it move from having ANC to delivery? And of course, because there's a correlation between delivery and income of women, and of course the index, how that also impacts on school performance. And we know, of course, school performance is determined on average by wealth status of the kids or parents. So moving straight up from ANC coverage to some kind of high index would be something that we we can do, but I would take the pinch of salt to be able to concretely say there is a relationship. The one we could do, however, is to see the relationship between that and maternal mortality, bearing in mind what I've said, that it's not a one-to-one relationship at all. And it's been, if you meet epidemiologists today, that's the first thing they tell you. You economists, you fail to realize that in the world of epidemiology, there are some other things beyond just moving. And that's the kind of thing that enriches discussions between health economists and epidemiologists and other health professionals. Yeah, you talked about visit not being the same between countries. Like I said, if you're looking at within country, I don't think one should worry so much, except you want to do cross-country comparison. But again, comes the whole issue. Previously, that was what was done. So they compare Ghana with Nigeria, Nigeria with Senegal, Senegal with Malawi, Malawi with South Africa, using a visit. But like you said, a visit in Nigeria may not be the same visit in Malawi or in Egypt. But unfortunately, that's what has been done before. So I agree, we may need to think hard when we want to do cross-country comparisons, but this wasn't intended for cross-country comparison. It was intended for two things. One is measuring the progress within a country. Remember, progressive realization. So monitoring progress within a country in terms of progressive realization. And the second one is to also monitor between groups what is happening. Is the gap closing or widening? Thanks.
Thank you. Do we have any other questions or comments? Anybody? Okay, so I have one extra question just to finish maybe. So have you also, because you show just one moment in time, have you measured this index along the years to try to capture any like policy intervention, like campaign trying to make women get more visits while pregnant, or I think that would be interesting to assess.
Yes, it's interesting to assess, but I have not. I've got requests to do that for the West African region. The challenge I'm having at the moment is capacity. But it's an area that I will look into. The two things. One is the quality, like I said, that one for me is prime, it's utmost. Then the second one is measuring performance over time within countries. But unfortunately, it's not been done, but I really want to do it. Yeah, perhaps maybe PEP might also be another avenue to get that done as well. Thanks.
Thank you. Yeah, I think it would be really interesting, and this is an area I think where you can have a lot of things to analyze and study and go ahead. Yeah. Okay. Thank you very much. If we don't have any further questions or comments, we can finish, and we stick to the time that was planned at the beginning. So thank you very much. This has been very illustrative, and so we'll see each other in 2 weeks.
I see a question coming. I didn't check the chat box. Sorry, I need to check the chat box and respond.
Ramos has one comment or question. Can you?
The soundness of the various axioms and property proposed on property indexes. I'm not sure whether that's a question.
Hi, John. Excellent contribution. I enjoyed that. I just wanted to know, when you were discussing the various axioms around your index, I didn't quite follow, the soundness of the axioms that you imposed.
Okay. Yeah. Okay. I'm trying to get my head around what exactly you want. You want me to either go over the axioms, or I'm happy to.
It's fine. Maybe you can share the actual paper. Maybe the details are in there. Yeah.
Yeah. Or
no problem.
The paper, I showed or maybe what I could do is I will circulate it via. Do I have all the emails, or I can send it to Carmen? I don't know.
Yes, there is a list, a distribution list with all our emails. So you can, I can send it to you. So I think everybody has it, or you can send it to me and I'll forward it to everybody.
Okay. No, that's okay. That's okay.
Okay, perfect. That will be perfect.
Thanks, Ramos. Yeah.
Okay.
Thank you. Other question?
Thank you, everybody.
Thank you. Bye-bye.
Connecting.
Okay. Bye. Yeah.
Bye.
Bye.